Welcome to the Doc Lounge Podcast, Crazy Cases series. In this series, we will explore some of the most unusual and interesting cases medicine has ever seen. We will speak with providers of all specialties from all over the nation. We will hear first-hand accounts from symptoms to treatments to cures. So sit back, relax, and let's explore some crazy cases. Hello, everyone. Thank you guys for tuning in to the Crazy Cases series of our Doc Lounge podcast. I am your host, Summer Gilbert, and my co-host today is Mr. Chris Kahl. Today on Crazy Cases, we have a good friend of our podcast, Dr. Russell Gross. Dr. Gross was on the Provider's Perspective episode last year. He also talked to us about rural recruitment, and today he's going to talk about some crazy cases. Dr. Gross is a board-certified general surgeon, and he's got many years' experience, and with that experience comes some cases that he definitely won't forget. So today, Dr. Gross is talking to us about 3 separate cases that stood out to him in his career as a general surgeon. So after this quick disclaimer is our episode with Dr. Russell Gross. And just a quick reminder, every episode of Crazy Cases is HIPAA compliant. All names have been changed and all personal patient information will remain private. So that being said, let's get started. All right. Well, Dr. Gross, thank you so much for being with us today.
Happy to be here.
And so with this case, the first case you're going to talk about, take us to the beginning. How did the patient or patients present themselves to you, and what were the symptoms?
Okay. Well, this is more of an interesting type of caseload. During the time I was in Tennessee, I probably did an average of 1 appendectomy a week. So in the 9 years I was there, it was well over 400. In the first 2 years, 8 of those appendectomies, and they were all for acute appendicitis, had cancer of the appendix. Now, we're not talking little carcinoid tumors, we're talking cancer of the appendix. And so in essence, the appendicitis saved their lives because it showed up early. So I had these 8 cases. 2 of them were sisters. All of them were fairly young. All of them had an appendectomy. One of them required a right colectomy because of the size of the tumor. All of them were cured. All of them were seen by oncology in Memphis, and none of them required chemotherapy. So it was just an interesting findings, because cancer of the appendix is not common, and here I ran into 8 cases. I don't know if it was something in the Mississippi River or genetics. The fact that 2 of them were sisters was pretty interesting. I did talk at some length with our pathologist about writing this up because it was kind of unusual to me, and he just wasn't really interested in doing that. So we just let it go, and that's just...
Yeah. In what time frame were these?
In about a less than 2-year period, 8 cases of cancer of the appendix.
And did the cancer have anything to do with the appendicitis?
It caused the appendicitis.
Okay.
So in that sense, it was diagnostic. Sorry. I'll just put this here.
Yeah. Crazy. And so 8 cases, and that was in Mississippi?
No, in Tennessee.
Oh, Tennessee, that's right. Because that's when you were working in rural Tennessee.
We were by the Mississippi River, so that was our source of...
Mm-hmm. And you were the only general surgeon in town, right?
Well, there was another one, but he didn't take any calls.
Gotcha.
So how abnormal was that to have that amount of cases with that type of...
That's extremely unusual. I've never done the research to see what the actual incidence, but I've done at least 1,500 appendectomies in the course of my career, and those are the only 8 that had cancer. I've seen carcinoid of the appendix, and I've seen metastatic melanoma in the appendix that I was operating on for other reasons, but I'd never encountered any cases of cancer of the appendix.
No, when you were in your surgical training, did you ever encounter those types of cases?
I don't remember ever seeing that before, actually.
So it must have been something, like you said, in the water type
Something
thing.
in the water. Yeah.
Well, and I think it's strange that two sisters.
And two sisters, yes. Not twins, but sisters.
Yeah.
Yeah.
Very strange.
And presented within a year of each other.
Wow. Huh. There's got to be something behind that. If it's all in one area.
Yeah, I really wanted to pursue it, but without the help of the pathologists researching it and getting tissue samples and stuff, it was
Yeah.
not going to go anywhere.
Wow. Well,
Interesting.
if any of you physicians are listening and you've had something similar, let us know. All right. Well, bring us to your second case that you're going to talk about. And then same thing. How did the patient present themselves to you?
A young woman shows up in the emergency room with acute appendicitis. And she's a tall, big girl. And so I'm doing the history and physical. And she's telling me that her son has had 2 operations for macroglossia, which is an enlarged tongue. And he's had 2 operations. A little, very young child has had 2 operations. Tongue is just too big, and they thought that she might have passed on Beckworth-Wiedemann syndrome, which is an abnormality of chromosome 11. So I said, okay, well, you got appendicitis in your appendectomy. So we did a laparoscopic appendectomy, and sure enough, her appendix was about the size of a hot dog. Usually an inflamed appendix may be the size of my ring finger. That's a big inflamed appendix. Hers was really big. But it removed very easily. I got it detached from the cecum and took the blood supply, and everything was fine. And in removing appendixes during laparoscopic surgery, you put them in a plastic bag and pull the bag out through one of the port sites, usually a 12 millimeter port site. Well, it wouldn't come out.
Because it was a hot dog.
Because it was a hot dog. So I'm kind of stretching it with the clamp and doing that. Anyway, the bag breaks and the appendix falls into the abdomen, and I have to retrieve it with a clamp, and I grab it, and it's a suppurative appendix. It's really inflamed. But I orient it correctly so it's longitudinal, and it now comes out pretty easily. And she did well, except she did develop an abscess. So I had to take her back to surgery after maybe about 10 days or 2 weeks. She came back in. She was discharged from the hospital after 1 or 2 days, but she came back with an abscess, which was very easy. I just opened up that port site and it drained it very simply. I put a drain in, and she recovered completely and did very well. So she clearly had this syndrome as well, the Beckworth-Wiedemann syndrome. And she did fine, but that's pretty unusual. I had never seen that kind of abnormality before, and had to look it up to find out what it all meant.
Like in a population of 100,000, how many people might have that?
1.
So she was the one.
She was the one.
Wow.
Yeah.
What's the correlation with the tongue?
That's one of the classic signs of this syndrome, is that the tongue is enlarged. The kid couldn't breathe at night. He would sleep back, and the tongue would fall back and block his trachea, and so.
So that was passed on genetically from
passed
either
on
the mom
from
or
her
the
to
dad.
him.
Wow.
Well, from her, because she had some signs of it too. Many or all of your organs internally are enlarged. So if I had really looked around, she probably had a big enlarged colon and stuff. But since I was focused on the appendix, that's really.
Now, after you removed that appendix, did all the other organs shrink back to normal size? Or
No, they stay the
that
same.
way?
Yeah, that's the syndrome, is that you have these large organs.
Mm-hmm. Can it become fatal because they're?
Well, in the son's case, it potentially could have if he hadn't had surgery, and one night he sleeps and doesn't wake himself up from choking. Yeah.
Huh.
So when you removed the son's appendix too?
No, I did not remove the son's appendix. The son was just the key that she had the syndrome as well. But she didn't have the macroglossia. She just had other organs, appendix specifically, which was enlarged.
Now, was that a case that you had previously seen, like through training or read it somewhere? Or?
Never saw it, never heard of it before.
And you had to just hit the books?
I had to hit the books, yeah.
Wow.
Find out what it was all about.
How does that happen? So do you look up, how do these books work? Do you look up symptoms first and then it gives you different...
Well, nowadays you can just type in macroglossy and it'll come up with that. But this is a little bit pre-app. So I actually had to go to the library to look it up and find out what was going on.
And was this in Tennessee?
Tennessee.
When you were rural?
All these cases are Tennessee. I didn't drag any of the other stuff over with me.
Now, when you said the medical library at the hospital, or just
at the
regular
hospital, they had enough research. You could find that.
Okay.
Awesome. Cool. Thank you.
Okay.
Any more?
Oh, sure.
All right.
Okay.
Let's keep
We
going.
can go all day.
Let's see.
And for you listeners, who just a little backstory is all these stories are coming from rural Tennessee, where how many years were you there?
9.5 years.
So Dr. Gross was working in rural Tennessee for 9.5 years, and he was one of the only general surgeons. So he saw cases from all over
the region.
and just, all different. Like he wasn't specializing in just one part of surgery, just, all different kinds.
Okay, the next case is something I know that I've seen before. This is a more common case, but the solution was a little different. So I'm in the operating room one morning, and I get a call from the ER. The town undertaker is in septic shock. I said, okay, start some IVs, run a bunch of fluid. As soon as I finish this case, we'll be over.
So you had a patient open.
Yeah, I had a patient open. So I had to finish the case. And besides, this guy needed to be stabilized a little bit. He was hypotensive, and he was sick as a dog. Anyway, the interesting part about the presentation is that he was being seen in Memphis for pneumaturia, which is air in your urine, which almost always signifies a fistula between the intestine and the bladder. Where else are you going to get air? And he was being worked up, and they hadn't made a diagnosis. But other than that, he was peeing air as well as urine. So that was the presentation, but he's in shock. And a flat x-ray of his abdomen showed free air, which means that he's perforated something. Mm-hmm. So that's clearly an abdominal catastrophe, and I needed to get him in surgery. He couldn't ship him down to his doctors in Memphis. He was way too sick for that. So we stabilized him in the ER and brought him to the operating room, and I did a laparotomy. And as soon as I entered the peritoneum, there was a whoosh of fresh air that came out. And his belly was literally full of stool. Everywhere.
Really?
He had exploded his cecum, which is the first part of the large intestine and the thinnest part of the intestines of the large intestine, and it was just wide open and just had exploded that, and he had spilled liquid stool all over his abdomen.
So that was already there when
that was
prior
already
to you
there
opening
when I
up.
opened them up.
Wow.
So I've now got to do salvage surgery because I just want to get him off the table alive, and we'll worry about figuring out what's next. His pelvis was all socked in, so I wasn't about to deal with the fistula or anything. So I did a very limited right colectomy, brought up the hepatic flexure, which is now the proximal part of the colon, as a mucus fistula so that it wouldn't cause obstruction anymore, and brought up the terminal ileum as an ileostomy so he could continue to pass his excrement through that bag. And that would, and then he had that socked-in pelvis, which was obviously also the cause of the obstruction, but he had backed it up all the way to the cecum. I had removed that part of the colon, but he's still got a belly full of stool, and I got to get him rinsed out because infection and abscess and sepsis will continue. So I'm thinking just pouring water in is not going to do it. What am I going to do to clean this belly? And I was thinking, who really wants to have clean operative fields? Orthopedics, right? Because they have to have absolutely sterile fields to do total joints. So I asked for the ortho irrigator, which is like it's almost like a gun, and it has both irrigation and suction, so you're not going to spill everything all over your feet. Orthopedics is very clean. They don't like to get too many.
Where you guys are dirty.
Yeah. So they brought me the ortho irrigator and hung up a big bag of fluid, put some betadine in it, and I started rinsing him out. And I rinsed out the right upper. I did it by quadrants: right upper quadrant, mid abdomen, lower quadrant, pelvis, and back and around and around. And I went through, I don't know how many liters of fluid, 10, 15, 20, but didn't make a big mess because it kept sucking it up as I was irrigating it out. And so I felt that I had cleaned him out pretty good and closed him up. And we got him off the table, and he was stabilizing, and put him in ICU, and he did very well. And the interesting thing after that, after he initially recovered, we did send him down to Memphis so that he could continue definitive treatment. And they found that he had bladder cancer, which is kind of unusual for that to fistulize into the colon. Usually it's diverticulitis or colon cancer will erode into the bladder. Mm-hmm. Those are the most common things. But he had bladder cancer. He had a total cystectomy, and eventually they put the two ends of his intestines back together as well, I guess at the definitive surgery. And he wound up doing fine.
So what would have happened if he didn't present at the time that he did? Because it sounded like he was
dead.
pretty bad.
Another hour and he would have been dead.
Oh, wow. Another hour?
Yeah.
And he brought himself in, or a family member? Or?
The family brought him in. Well, they called the ambulance. I don't know for sure because I was in the operating room when he arrived in the ER. So I'm assuming he was brought in by ambulance. They just didn't feel they could get him all the way to Memphis, which was another 45-minute drive. So obviously the EMTs must have thought that he was
that close.
In dire straits. Yeah.
And so one of his first symptoms, he's saying he had air in his urine.
Yeah.
So it's just bubbles when you pee. How would he know?
Yeah.
Wow.
It kind of fizzes as it comes out.
Yeah. Interesting.
Wow, that's crazy.
Scary.
That's the crazy case.
That's crazy case.
Scary.
That they let him. That he presented with that in Memphis though previously, and they were doing a routine workup because he didn't have any really sick signs other than this pneumaturia.
So it sounds like in surgery you don't have too many of those things where you have to really clean them out, like you said, the orthopedist
It's uncommon. Usually most infections are local. The abdomen is able to wall itself off very nicely. So oftentimes, even if you have a perforation, unless it's real sudden, like a duodenal ulcer or something, which freely spills into the abdomen, these things will isolate themselves, so they'll be more localized. And once, if you encounter them, you can just pop a finger or a clamp into it and it'll drain, and you can just put a drain in and they'll heal up. But his was real generalized fecal peritonitis. It was really bad.
So the facility you were in was a smaller hospital?
Yes, it was a community hospital.
So if this patient presented at a bigger center, would they have treated the patient differently, you think?
No, that was salvage surgery all the way. Yeah.
Wow.
What made him come in the emergency abdominal pain? Was he like?
I guess it must have been the pain. Yeah.
Yeah. Crazy. All right. Well, let's keep going.
Okay. Let's see. Did that, and that. I have one last case. It's really fairly routine, but it's really a happy memory for me. So I would like to talk about it. Either the first or second year I was there, my kids are still very young. Maybe they're 8 and 5 or 9 and 6, very young. And what we would do is we'd be there till May when school went out, and then everybody would come to California because all the family is here. And then I would come at the end of the summer, and we'd all go back for the start of school in August. So I would take vacation in July or whatever. Anyway, this year I brought the kids back myself, and my wife stayed to hang with the family another week or so, we did that all the time, so she could have a respite. Mm-hmm. And so it's only the second year we live out in the country. I mean, we're rural and we're living out in the country, so I'm still not entirely comfortable with the whole thing. And the kids are quite young, and so it's a Saturday night, and I get the 2 o'clock or 3 o'clock in the morning call, and they have a young fellow in with torsion of the testicle. Now, this is a real surgical emergency because you only have a few hours before you lose the testicle. Okay, so you have to restore the blood supply. And most places I've been, usually urology would do it, but our urologist didn't take calls, so they called me, and I said, okay, fine. And I said, call the crew, and I'm on my way. So I'm up easy, and my kids are sleeping, and I don't want to leave them in a house out in the country, 2 young girls.
Right.
So I say, okay. So I wrapped them in their blankets, the thin blankets. It's August, it's hot. Put them in the Odyssey and drive to the hospital, where I put them on the couch. They both fit on the couch.
Were they sleeping the whole time?
Oh, pretty much.
Yeah.
Put them on the couch in their blankets, and it's in the doctor's lounge, so it's a locked room. And I go and I operate on the young fellow, and he's, I don't know, a teenage boy. And I got him into surgery in less than an hour, so that's really pretty good. We untorse his testicle, wrap it in some warm, wet towels, and watch it pink up, and did a pexy to the scrotum so it won't twist again, and put him to bed, and he did great. But that's a couple days later. So it's now 6 o'clock in the morning, and 7 maybe, I don't remember exactly when. The girls are starting to wake up, and I said, okay, that's good. It's Sunday morning, and wake them up, and they're still in their jammies, but we go just down the street to the local cafe, have a nice pancake breakfast, and spend the rest of Sunday hanging together. So to me, it was not a crazy case, but it's a memory that I don't remember a lot of details of a lot of the surgery that I've done, but I'll never forget that day, that night, and that morning. That's a real good memory for me.
Yeah, being able to bring them along.
Yeah.
You know.
No,
Now, did anybody show up in the doctor's lounge and see 2 kids sleeping there? Whose kids are these?
At that time, nobody's up that doesn't have to be up.
Right. Yeah.
Yeah.
Do you lock the surgical room so that if they got up, they couldn't come in?
Well, they could get out, but nobody could go in if they didn't have the code. It was a code.
Oh, okay.
Key code.
Gotcha. Back to that patient, what caused that torque?
That's actually not uncommon. That's a fairly routine thing. I've seen several of those in my practice in California, so it was not an unusual case. But what happens is that the testes is floating freely, basically, in the scrotal sac, and it can twist. And if it twists, it cuts off the blood supply, and so you need to get in. You have a few-hour window before it's irrevocably damaged.
What's the most common reason for that?
Just
the movement. Just
like
the movement.
sports,
yeah.
or
Actually, I'm surprised it doesn't happen more often.
Huh. Sounds painful.
It's very painful. It'll bring you in right away.
Yeah. Wow.
And that's the only way to take care of it.
Yeah.
Wow. Well, thank you so much for chatting with us and joining us.
Yeah, it's kind of fun to do.
Do you guys have any questions? I know we just have a couple people on here. But thank you so much for
happy to share
all your stories. And Dr. Gross also has on our podcast right now his story of rural recruitment. So you can go and listen to that. So anyways.
I hope I've been of some enjoyment to anybody who's watching. It's fun to share.
Of course. All right. Well, thanks, Chris, for joining us.
Anytime.
Thanks, you guys, for joining us, and we'll see you later. Thank you to all our listeners. If you'd like to be notified when new episodes air, make sure to hit that subscribe button. And a big thank you to Pacific Companies. Without you guys, this podcast could not be possible. If you would like to be a guest, go to www.pacificcompanies.com. Thank you.